Hey everyone, and welcome to The Explainer. Today, we're tackling something literally every single emergency physician is going to face on the front lines. It's a total household staple, found in just about every medicine cabinet across the globe. Yet, paradoxically, it's actually responsible for over half of all acute liver failures in the US alone. We're talking, of course, about paracetamol, or acetaminophen. So let's just jump right in and break down the absolute latest clinical pathways to manage this critical toxicological emergency.
You really kind of have to wonder, right? How does a medication that is so generally safe and heavily relied upon become the second most common cause of liver transplants worldwide? Well, here's the clinical trap. Patients who take a massive overdose, they often walk right through our ED doors completely asymptomatic. Maybe they have a little mild GI upset, but that's it. There are no flashing red lights right away. And that makes our rapid algorithmic response absolutely critical.
All right, here's our clinical pathway today. 1. The silent overdose threat. 2. Diagnosis and risk assessment. 3. Initial management and decontamination. 4. The 2-bag NAC regimen. 5. Disposition and safe discharge. And 6. Summary and key messages.
Section 1. The silent overdose threat.
Before we look at the clinical algorithms, we've got to understand the why behind the management. Interestingly, the drug itself isn't even the direct villain here. It's the metabolite. Under normal conditions, paracetamol is safely metabolized. But in an overdose, those normal pathways totally saturate. The overflow gets shunted over to the cytochrome P450 system, specifically the CYP2E1 enzyme, which churns out this highly reactive, incredibly toxic intermediate metabolite called NAPQ.
Now, your liver normally mops up NAPQ using an antioxidant called glutathione. But in a toxic ingestion, that massive influx of NAPQ rapidly depletes your glutathione reserves. They're just gone. And once it drops below critical levels, NAPQ starts binding directly to liver cell proteins, causing massive hepatocyte necrosis. This destruction happens totally silently at first, which is exactly why intervening within that first 8-hour window is quite literally the difference between life and death, or getting on a transplant list.
Section 2. Diagnosis and risk assessment. Moving out onto the ED floor, the most crucial thing is establishing baseline risk. For an acute single ingestion in an adult, your toxic threshold is 10 grams or 200 milligrams per kilogram, whichever number is less. If a patient crosses that line, they are officially at risk for acute liver injury, and we need a standardized evaluation right away.
But, not all ingestions are that straightforward. We absolutely have to differentiate between an acute single ingestion, which actually includes staggered doses taken within a super tight 2-hour window, and a repeated supratherapeutic ingestion. That's where a patient is taking excessive doses over, say, 24 to 48 hours, often just trying to treat a stubborn fever or pain. This distinction is huge because the standard diagnostic tools we rely on for acute overdoses simply cannot be used for repeated ingestions.
Which brings us to the holy grail of tox, the Rumac-Matthew nomogram. You plot the serum concentration against the time of ingestion to figure out if NAC therapy is needed. But remember the massive caveat here. This nomogram is strictly validated for acute, immediate-release ingestions where you actually know the time of ingestion. You cannot use it for repeated supratherapeutic ingestions. And you've got to wait until at least 4 hours post-ingestion to draw your level so the drug fully absorbs. Hits the line, you treat.
Section 3. Initial management and decontamination.
When that clock is ticking in triage, your immediate actions set the trajectory for the entire clinical course. This pathway anchors our decisions right on the time since ingestion. Under 2 hours, think decontamination. Between 2 and 8 hours, we wait for that 4-hour mark to draw levels and plot the nomogram. But, and this is so important, if they present after 8 hours, or if your lab turnaround time means you won't get results before that 8-hour mark, do not wait. You start that NAC infusion immediately to protect the liver, and just check your levels concurrently.
I mentioned decontamination a second ago. Activated charcoal has a super specific, very narrow role here. A dose of 0.5 to 1 gram per kilogram can be given to stable, alert patients if they present within 2 hours of a toxic solid ingestion. But do not use it if the patient has an altered mental status or is vomiting. Protect that airway first. Charcoal is strictly for your early, uncomplicated presenters.
Section 4. The 2-bag NAC regimen.
Okay, let's talk definitive antidote, intravenous N-acetylcysteine, which replaces that burned-out glutathione. And we really need to highlight a major paradigm shift here from the older, kind of clunky 3-bag protocol. The modern standard of care is a simpler, much safer 2-bag regimen. Step 1 is your initial infusion, 200 milligrams per kilogram given over 4 hours. Step 2 is the second bag, 100 milligrams per kilogram given over 16 hours. This continuous 20-hour course drastically cuts down the dosing math errors from the old system, and it definitively lowers the rate of adverse reactions.
Speaking of adverse reactions, let's address the elephant in the room: non-allergic anaphylactoid reactions, or NAAR. You start the NAC, and the patient gets flushed, maybe they break out in hives. Look, it's vital to know these are just direct, dose-dependent histamine effects, not true immunologic allergies. If it happens, halve the infusion rate and give an antihistamine. If it's severe, pause it briefly, treat it, and restart at a quarter rate once they feel better. But the absolute golden rule here is do not permanently stop life-saving NAC therapy over a transient histamine release. Section 5. Disposition and safe discharge. Fast forward 20 hours. That second bag is emptying. How do we know it's safe to unhook the patient and send them out the door? You have to run through a strict end-of-treatment checklist. Do not just stop the NAC early without consulting tox. Before you pull that line, confirm that the liver enzymes, ALT or AST, are either completely normal or clearly downtrending by 25 to 50% from their peak. The INR must be less than 2. The patient has to be clinically stable. And finally, the paracetamol concentration must be practically undetectable, specifically less than 10 milligrams per liter. All boxes checked, they are medically cleared for discharge or a psych eval.
Section 6, Summary and Key Messages. We've covered a ton of ground for your next fast-paced shift. Let's rapid-fire the highest-yield clinical pearls. Number 1, act swiftly when that 10 gram or 200 milligram per kilogram threshold is breached. 2, precisely plot known acute ingestions on the nomogram, but never before the 4-hour mark. 3, utilize that simplified 2-bag NAC regimen, it's just way safer. 4, treat flushing and rash as the histamine release it is, but never abandon your NAC. And finally, confirm every single strict laboratory exit criteria before you clear a patient.
It's a pretty sobering thought to end on, right? A routine dose of paracetamol is virtually harmless. But when that threshold is crossed, your structured, precise timing in the ED is truly the only thing standing between your patient and the liver transplant list. That 8-hour window does not forgive. So, with these modern pathways in your back pocket, are you ready to beat the clock on your next shift? Thanks so much for joining me for this explainer, and I'll see you next time.